So thanks for joining us again for discussions and diagnosis. I believe this is our fifth session, and we've certainly had some very interesting discussions before. We're going to try to alternate clinical discussions with theory and research. So last week, Owen O'Sullivan discussed cognitive error and its role in diagnosis, and specifically a cognitive forcing tool that he had developed together with his colleagues to try to mitigate the problem. But I think most importantly, he highlighted some of the difficulties in doing that sort of research, not just in yielding a positive outcome. So this morning, we're very privileged to have Dr. Bobby Hughes, who's from the Department of Emergency Medicine here at University Hospitals and Case Western Reserve at University. Bobby's been here for several years, has a broad range of interests within emergency medicine and quality improvement in particular. So he's going to discuss one of the most challenging, I say one of the most challenging because I think abdominal pain is still number one in primary care, as well as in terms of emergency department visits. So Riley Grosso is going to discuss that next week. But this week, we're privileged to talk about chest pain in the emergency room setting. So welcome, Bobby. Thanks for joining us this morning.
Thank you so much for having me. Hi, can everybody hear me okay? Is my audio a little soft? Okay.
Yes, I can.
Okay, thank you so much. Sorry, I've been having mic issues and I tried to troubleshoot last night, wanted to make sure we were okay. Just a quick advisement, if you are driving on the east side today, please give yourself a little extra time. The roads are horrific. I was excited to make it here on time after an hour drive. So Gautam, where do you want to start?
Okay, well, thank you, Bobby. Let me make sure we get the spotlights on everybody. There we go. Should work. Oops, I'm sorry. Just give me 1 second. There we go. Okay, perfect. Thank you, Bobby. Thanks for the advice about driving on this snowy morning here in Cleveland, Ohio. So I thought we would actually start with a case study, which is always an interesting way to start these clinical discussions. So let's consider the following situation. We have a 62-year-old woman. We're going to call her Mrs. H. She has a history of well-controlled hypertension and obesity. Nothing else really. She does not have diabetes. She doesn't smoke. She doesn't have a family history of heart disease that she's aware of. She's otherwise generally healthy. She had hysterectomy in 2009, so 14 years ago. And she presents with a funny feeling in her chest to the emergency room. And it's been going on for 10 to 12 hours. It's kind of late in the evening right now. She originally dismissed this feeling as indigestion, but her daughter was visiting her in the afternoon and said, hey, you better go to the emergency room. And she arrives, she's looking really quite well with normal vital signs. She actually rubs her upper left chest, indicating that the discomfort is still present and it's actually getting slightly worse over time. So somebody gets an EKG almost immediately. It shows normal rate, normal rhythm. There are no ST segment changes whatsoever, but there's a couple of inverted T waves in the two precordial leads. There's no prior EKGs available. So fairly typical situation that you probably encountered, I would think a couple times a shift, if not more. So I guess the broad question is, where would you take this from here? What would you do?
So first of all, this is my favorite type of topic. I love how we approach the clinical decision making, particularly in the emergency department, because of how undifferentiated our patients start and where they end up. Because you can give me 50 different patients with chest pain, and depending on multiple variables, including the patient's age, their race, their sex, their comorbidities, it could be one of any differential diagnoses on the back end. So a 62-year-old female with a history of well-controlled hypertension is automatically, in my mind, a little bit of a higher risk group. I give a little talk in the emergency department when I'm teaching learners, medical students, or residents on being a good diagnostician and leveraging some of these information points immediately before you even go and see the patient is really important to start to drive a broad differential, because chest pain can be anything. MI, of course, comes sort of first and foremost in our mind, and the way the case is constructed here really sort of pushes you down an ACS type of path, an acute coronary syndrome path, especially with those T-wave inversions. But it could be anything from a pneumothorax to a PE to a dissection, could be something really minor like a little chest contusion because mom hit her chest on the counter the other day and more of a traumatic injury. So the approach really begins with a really robust history and physical exam, really understanding what the onset is of the pain, the cadence, the intensity, what makes it bad, what makes it better, because these start to drive our shuffling of our differential diagnosis and really help us start to flesh out where we think we need to take potential testing if we need it to sort of further prove or refute the point.
Great. Well, thank you, Bobby. So let's say that you've done that. You've got the history, the physical exam, and she's kind of almost reluctant to be there. She doesn't think this is a serious problem. Can you take us through, given that EKG situation, what sort of testing would you think is automatic or based on protocol, based on your experience and work?
Sure. And this is where I think things are very interesting. I think as a clinician, doctors consider themselves artists on some level because every patient is unique, and they are. But we've done a lot of work in medicine over the past 3, 4, 5 decades on developing clinical decision rules that we can apply to patients based off their presentation and based off your clinical impression of what their differential may be. So a patient like this, if I'm going down the acute coronary syndrome sort of thought process, there's certain things that I do want. I'm going to want to check a troponin on the patient. I'm going to want to obviously check the EKG. If there's an old EKG for comparison, all the better, because sometimes those T-wave inversions were present in 2009. And the 62-year-old female who's had a long-standing history of hypertension is in fact developing some longitudinal heart disease, and that may be a very routine thing for her. Now that gives us a little bit of upfront information combined with a history and physical. And so assuming the history leads us to believe this might be acute coronary syndrome and applying a troponin and applying an EKG, we can now leverage some of our clinical decision tools. So the heart pathway is used currently at University Hospitals, Cleveland Medical Center, actually across our entire emergency medicine network, which is a combination of the history, the EKG features, the age of the patient, risk factors, and a troponin. Now, if the heart score is in a low risk bucket, 0 to 3, then the patient has a risk of a MACE event or major adverse cardiac event in 30 days. And depending on the literature you look at for the validation studies, anywhere from 0.9 to 1.3%. And so that is sort of our acceptable level of risk for a patient when they come to us in the emergency department. Because if you think about how truncated their visit is, it's a very short time. Often we add a delta troponin to a patient's presentation, anywhere from 1 to 3 hours after the initial troponin, but that very much depends on if you're using the high sensitivity or not and what your thresholds are to achieve an adequate data set that would give you some reliable information on delta change over time. But that would be my initial approach to somebody like this, assuming that the only consideration up front is ACS, although we all know that there are a broad set of differentials that I would consider on top of that.
Of course, yeah. So that's great. So I think ACS kind of dominates your decision making early on, though you're thinking about other things as well as a cause of chest pain, as we must. So let's say she's feeling reasonably well. We'll take things a little further. The high sensitivity troponin is negative. The delta troponin is negative. She's still in the emergency room. She wants to go home. What do we do? What do we do now?
Yep. I love having conversations with my patients at the bedside. So applying the heart score to this patient, she gets I would say a 1 to 2 for history. And I'll admit up front, part of the biggest critique of some of these clinical decision rules are the variability of the subjective portions of it. So the history of a patient's presentation is going to really drive a lot of the scoring. You can imagine that a 0 and a 3 are not necessarily the same in terms of their risk profiling. They're bucketed in the way that some of these clinical decision rules are sort of parsed out, but that's for ease of application. Really, a 3 to a 4 has its own sort of nuance. So this patient's going to have a high low risk or a low moderate risk heart score, depending on the way that the entirety of the case sort of played out. So a person like this, I have a very frank discussion with at the bedside. Mrs. Smith, you're 62, here are your risk factors, and here's how I've interpreted your presentation today. While your heart enzyme was negative when I first saw you and negative now, if you're having continued pain, that's concerning to me, and I would like to keep you in the hospital overnight for some additional testing. That's when we can consider some of our accelerated clinical diagnostic pathways that we have in our observation area in the emergency department. We can perform stress tests or stress echoes, cardiac coronary CT angiograms with some fractional flow reserve on the backside. And so I have a discussion with the patient and ideally family members as well to come up with a good strategy for approach. Very often we engage in shared decision-making with patients because in that micro moment in time, I know full well that I'm just getting one page in the entire book that is their healthcare novel. And be that as it is, the chapter may end very different than how I'm looking at the patient now. And so the older the patient, the more they have specific risk factors that make them at risk for atypical presentations of ACS. So the very old, the very young, patients who are multi-comorbid, patients of an African-American descent, these are folks who may have atypical presentations. And I have bells go off in my head. And if we get time to talk about the article at the end, that really supports a lot of that thought process. But that's the conversation I have with the patient. And sometimes people want to go home, and that's okay. But the key here is to make a decision with them, number one, depending on the risk factors, and then have a good discussion with them about the return precautions. If this pain comes back, you come back to me. If something changes, you come back to me, and then setting them up with follow-up.
Great, thank you, Bobby. So it's interesting. I mean, you're thinking about admitting her for observation overnight, perhaps getting a stress echo, perhaps some additional laboratory testing, I suppose, later on. If she really wants to go home, would you arrange for those things the following day somewhere? Or how? Okay.
That's a great question. So depending on the health system you're working in, you have opportunities to either leverage pre-existing pipelines into the outpatient pathway in the ambulatory space, or you try to co-create those over time because they are beneficial to patients. We often will see patients who are unaligned with healthcare. I think that's one of the biggest gaps in healthcare currently that we're facing, and probably exponentially worse now than it has been in the past, given the past 3 years and people with job loss or change in their insurance coverage. But aligning with these clinics or opportunities for advanced testing in areas that can meet those patients where they are, whether they have insurance or not, whether they're aligned or not, I think is really important. We're fortunate here at University Hospitals that we have a lot of those pathways to engage, and our HHVI, or Harrington Heart and Vascular Institute, is very engaged in helping us in the emergency department pipe these people to appropriate locations.
Great, thank you. All right, let's talk a little bit more broadly, because this, I think, is the real meat of the discussion. So what do you think the biggest challenges are in making an accurate diagnosis in patients with chest pain?
There's a lot. So when a patient first comes in and they have chest pain, it could be anything. I mean, anything. I have seen people who have stubbed their toe, die of a cardiac arrest within a couple of hours later. The emergency department is a very interesting place to practice clinical medicine because of the undifferentiation up front. But that said, it's not that hard to envision a relatively broad differential diagnosis for a patient with chest pain that is sort of flavored by their age and their risk factors and their comorbidities. So the older patients who have hypertension and acute coronary syndrome, I start thinking a lot more about ACS, and that starts to shoot a little higher up in my differential. A patient who's had a history of multiple PEs and DVTs, who has a pleuritic component to their pain, a little hypoxic, maybe tachycardic, red flags start to go up for a pulmonary embolism, traumatic injury, pneumothorax, hemothorax. There's a whole host of different things that start to come to mind that I can conjure based off risk factors. But therein lies, I think, some of the clinical challenge with this, in that people who are specifically at risk for a thing already conjure up my thoughts of a potential diagnosis. It's the people who aren't. So I wanted to actually bring up Jonathan Larson. So if you're not familiar with Jonathan Larson, he's the person who wrote Rent, which is one of my favorite Broadway plays. I loved it, saw it multiple times when I was a kid. Jonathan Larson ended up passing away from an aortic dissection, something that would be in our differential diagnosis. But he had 3 ED visits until it was finally caught, and it was too late, and he had died. Now, part of the trouble was Jonathan Larson was very young. Jonathan Larson had a bit of an atypical presentation, if you sort of read some of the information on the case. But he illustrates the point of the challenge, which is just because somebody's 18 doesn't mean they couldn't have a heart attack. And so taking these pools of patients and doing assessments longitudinally of what their risk factors are really help drive some of our awareness of the potential for the differentials the patient could have in the department. And we really need to just be conscientious of the people who fall into that outlying 2.5% on either side of the bell curve.
Great, thank you, Bobby. So what I'm hearing you say, first of all, it's the broad differential that underlies chest pain that makes it challenging. But also, I think our own biases. If I see a 70-year-old man, smoker, hypertensive, diabetic, chest pain, crushing retrosternal inequality, of course, I'm thinking acute coronary syndrome. But the youngish woman who doesn't have any risk factors, who presents with similar or atypical symptoms, we're kind of stuck with how to evaluate her. Okay, can you think of any personal cases that you can share with us that have presented especially interesting challenges?
Yeah, I think it's the young people. There's one thing that I want to add to this though too.
Mhm.
It's not just the young. Sometimes, and as we practice in an emergency medicine environment that is increasingly strained by patient boarding, by increasing volume, intensity, acuity, delays in care over the past couple of years, things have gotten even harder. And so emergency departments are starting to subdivide their department into areas of rapid clinical practice for low acuity and higher acuity areas. Now, the pitfall with that is that geography plays into the bias. And so not only is there now an age bias when you go and see a patient who's 18 who has chest pain and you're like, this couldn't be an MI, but they've been dispositioned to an area of low acuity in the emergency department that automatically reframes the way your brain is operating. And it adds a layer of need for you to pause, take a second, and just really think, is this an MI? And make no mistake, the history and physical drive the decision-making to pursue additional testing. Just because a patient has chest pain does not mean that they need an EKG and a troponin and a BNP and labs. What it means is you have to think about the differentials. This is the conversation I have with my learners regularly, because it's incumbent upon us to perform a good history and physical to decide what testing we need to support or refute that differential.
So just to clarify, you've got this 18-year-old, let's say, young man who has chest pain. That patient would automatically be triaged to a lower acuity area before you've seen them?
If they have stable vital signs and we get EKGs automatically on our chest pain patients, because this is the exact reason why you can catch an atypical presentation of ACS. But yes, if they're young, they're stable, and we have the opportunity based off their presentation and their history, and our triage nurses and triage protocols are really, really good at applying some of these rules. We filter them into a lower acuity area because they probably require less testing and they probably can move through the system a little quicker.
Okay, thank you. So I want to talk a little bit about what you think we can do broadly before we get to the article from Diagnosis. But what do you think, where do you think the big points of improvement are in terms of diagnosis? What do you think, what measures, what tools, what clinical decision support do you think could improve things?
We'll probably get into this a little bit more as we discuss the article, but I think using clinical decision rules when appropriate and where appropriate are hugely helpful, because these are validated clinical decision tools that allow you to reach a point where you have assessed a patient in an evidence-based fashion that spits out a very specific risk that you can then discuss with the patient. Hey, based off this and this and this and this in hundreds of thousands of patients that we have looked at, this is where you sort of land in the risk profile. If something changes or gets worse, you come back to me, or I now know that you need to be admitted and stay in the hospital, and here's why. But it really informs the decision-making on the back end. As we move forward in medicine, I think medicine is going to become even more collaborative with our patients as they have wearables that start to spit out EKGs, that start to give them information on their heart dynamics. All of this stuff is going to have to be folded into our clinical practice. And I think a lot of it is going to inform this sort of co-decision making as we partner with our patients over time.
So do you think we have a problem of underuse of some of these clinical decision-making tools? I mean, you're probably using them, but is that common?
I think it could be better used. Yeah, 100%. I think they exist. The decision to use the tool, I think, is sometimes the hardest piece. And the heart score, without going on too much of a tangent, a score of 0 for the history means it might be ACS. Not that it's not ACS. So if somebody got popped in the chest with a fist just prior to coming in and they say, my chest hurts, ACS is not in my differential for that patient in so much as I would apply the heart score. So understanding the nuance of some of these tools that we deploy and use, I think need to be blended into education a little bit more. And I'm really proud that my faculty use these tools regularly in order to do that, because we're trying to bring up the next generation to practice a little bit more evidence-based, understanding that the art sort of lays in between them.
Yeah, that's a great point. And I think it speaks to the broader issue of how do we get people to use clinical decision support? It's not easy. My own experience and work in this area is based on peer support. If I say, if I get a little alert that says, do you know Dr. Bobby Hughes is using this every single day? Well, oh, okay. Well, I might want to use this tool too, because he's a peer that I respect, for example. So that's one approach to it. But I think you're right. If we just use them more often, we would miss fewer cases of acute coronary syndrome. So I
Your point
wanted
about
this. Go ahead, please, Bobby.
All right, to your point about peer learning,
Yeah.
I'm actually right now at our Emergency Medicine Quality Summit. That's why my office looks a little different right now. And here at the Emergency Medicine Quality Network, which is actually led by Dr. Riley Grosso, who will present next week, the entire point of the existence of this network is exactly that. And I think those networks of linkage of clinical practice for peer learning, shared learning over time, quality review is exceedingly important to really raise all boats. And I think I'm really proud to be a part of an institution that has something like that.
That's terrific. And we really look forward to hearing from Riley next week. So I wanted to discuss this article. So this is an article that was published in Diagnosis, and we can certainly send out the link to those who are interested. But it looks at almost the epidemiology of chest pain and missed acute myocardial infarction in the emergency room. And among several 100,000 patients across the United States, it was roughly 1% of patients who came in to the emergency room with chest pain were discharged home, and often discharged home with various diagnoses, atypical chest pain being the most common, and subsequently were readmitted to the hospital within 7 days with an acute myocardial infarction. What were your big takeaways from that, Bobby?
Yeah, I think it was really important. There were a couple really key points that I think I want to bring up. Number one is the people who left against medical advice were excluded from the analysis. And the reason why I bring that up is because it was in the fine print that 13% of those patients within 7 days were admitted with an AMI. And so I think it's really important to understand that when patients make a decision jointly with a doctor, I'd argue we as a medical profession could be better with the AMA discussion. Oftentimes it results in a bit of a staticky relationship with folks, but it should not. It's decision-making that the patient has made and setting them up for success to sort of understand the return precautions, even more important with the patient that's going to make a decision against what you think ought to happen. I also think that 13% really lends itself to how we understand the potential for chest pain to progress, because it was 0.9% in the population overall, but 13% if they left when I said they probably shouldn't. And so that implies a pretty good catch rate. The other takeaway from this is that when you look at application of some of our clinical decision rules, not to sort of wheel it all the way back to the beginning, but you have the heart score, which is calibrated to about a 1.5 to 1.7% risk of major adverse cardiac event. But that's on purpose, right? It's the very same reason why when we start hunting for PEs, we have an acceptable miss rate of 1.5 to 1.8% based off how the PERC score is calculated, because we're aiming for equipoise. If I do something, I may hurt a patient just as much as if I do nothing. If the patient goes home and they have an AMI, that sucks. If the patient comes into the hospital and they get a nosocomial acquired infection, that's not great either. And so when we look at the 0.9% miss rate, I was actually pretty impressed with it because prior literature has shown close to 2. This is about what we are aiming for, but I would say that very certain demographics need to be looked at carefully. It's not just the AMA population, it's also the people who are very young, as we talked about earlier. It's the people who are African-American, low socioeconomic status. Interestingly, patients who were coming from a higher acuity, higher volume facility actually did a little bit better and had less major adverse cardiac events, including teaching institutions. And I think part of this is because we just have our hackles up all the time of the potential for somebody to have an atypical presentation of a cardiac event. But I think those were the major presentations of this. I thought it was a little limited in that it really only looked at association and not causation. It looked at the 7 days prior and just said, well, did this person who had an AMI present 7 days ago? That person could have presented 7 days ago with 2 normal troponins with an appropriate applied heart score, because they didn't look at the clinical parameters of what made up the decision-making for the patient to go home. You know, they could have gone home with ST segment elevations in leads that were not anticipated, or they could have gone home with, and this is an entire other discussion, atypical EKG features of STEMI, AVR elevation with diffuse ST segment depression, big deep T-wave inversions, Welland syndrome. There's a whole host of things that don't typically fit the STEMI profile as we prior know it. There's a current intent to try and change some of the nomenclature to OMI and NOMI, obstructive myocardial injury and non-obstructive myocardial injury, to account for some of these things. But those were my major takeaways from the paper, is that people who are not your typical 70-year-old with crushing chest pain, that's the person we may miss, and that's the person who needs extra attention.
Great, thank you, Bobby. Yeah, that was a fantastic summary of the article and some of the key features. I was actually impressed too with the less than 1% sort of misdiagnosis of acute MI, if you can call it that. And I think if you're missing no diagnoses, in other words, you're 100% accurate, there's something wrong with how you're defining the diagnosis for the most part. So we've got just a couple of minutes left. I want to throw it open to any questions or comments from our pretty large audience this morning. Please go ahead.
Hey, Bobby, this is Raj. That was excellent. Could you comment a little bit about the medical legal aspect of chest pain that comes into decision-making in the emergency room?
Yeah, it's a great question. And that's where I think, Raj, applying clinical decision rules is exponentially more important, because they give you some footing for the reason and rationale you did something. Chest pain and I think abdominal pain are two of the biggest medical legal risk diagnoses in the emergency department. Missed AMI and missed fracture are two of the biggest as well. So applying these rules, I think, equally, and trying to be really careful in the way that you assess the more subjective components of it, the history, right? Really understanding what the potential is for that 65-year-old female with diabetes who may have presented with weakness. Again, this paper actually only looked at people who had AMI with a DRG of chest pain or equivalent, something similar. They excluded the atypical things from this paper. And so when a patient presents with something that says this might be a heart attack, that's when we should evaluate and be very cautious. But I would argue the increased caution levels should come with the ones that didn't fit the profile for the 112,000 people enrolled here, the people with just weakness isolated. That's a really common atypical feature of ACS. So I would hope it doesn't play a ton into the decision to admit or discharge, because I think if you lean into the clinical decision rule, it gives you a lot more footing. Although I think just in general, people's utilization of the rules, to Gautam's comments earlier, probably need to be better. And that's where the shared peer learning comes into play. And I think as we get a little bit more facile with that as a specialty, we'll start to see improvement.
Thanks, Bobby. Thanks, Raj. We'll take one more comment before we have to wrap up. Anybody else?
I have a quick question about if you could briefly address how you document the joint decision making for medical legal purposes.
That's a great question. So our college, the American College of Emergency Physicians, actually has some pretty good templated literature on this. So you can create dot phrases within your EMR, any of it really. But I think at the end of the day, it's a combination of assessing a patient's competency, making sure they understand what's happening, or having a really good close family member or colleague, even they can have a conversation with them, understand the risk.
Could everyone please mute your phones? I'm having a very hard time hearing.
But anyway, to say it's a good question. And what we need to do is we need to sorry, I even kind of forgot the question there at the end.
Yeah, the question was about documentation of shared decision making between physician and patient.
Right. It's making sure they understand the risks in the circumstance where they have capacity and you've assessed that, and then getting them a follow-up plan, right? And again, just to sort of harp on it, the AMA discussion, the Against Medical Advice discussion for all of us as clinicians benefits from a partnership relationship with your patient, understanding that like they got to go feed their dog, or they have to go take care of their grandma, or they just had a bad experience today and they want to leave. But it does not mean that they don't deserve appropriate follow-up and connection to the healthcare complex on the back end of things and setting them up for success, because that's a massive risk pool, as this paper showed.
Thank you, Bobby. Thank you so much. Great discussion this morning, everyone. Thanks for your questions. Thanks, Julie. Thanks, Raj. We will see you next week. And then Dr. Riley Grosso will be speaking about the other major challenging problem in the emergency room, or one of the most challenging problems, which is abdominal pain. So until then, have a wonderful weekend and a wonderful week. We'll see you then. Bye-bye.